Alright everybody, for this pre-lab video, I'm going to go over how to insert and use an i-gel. So the i-gel is a supraglottic airway, so it sits above the glottic opening in the back of the throat. What this does is it enables us to more effectively ventilate a patient who is not able to breathe on their own. So this is what we place on a patient where we have an OPA in place, we've been ventilating them for a while, we are unable to reverse the cause of them not breathing, so we are going to put in something that will secure their airway better than just the OPA does. So the advantage to the i-gel is it seals completely around the top of the trachea, thus making it so that no air can escape down into the esophagus and cause our patient to vomit. So when you open your packaging, it looks like this. So the first thing you're going to do is pull out your i-gel. Do not throw away your packaging because you actually need it. You're going to take it out of the green holder. That can get thrown away because we don't need that anymore. But we do need the plastic base here. So when we're pulling this out, we need to make sure we get the correct size. If you look up here, this is a size 4 and it's for 50 to 90 kilogram patients. So that is ideal body weight. Not how much they actually weigh, it's how much they should weigh, which is difficult here in America because most people are not their ideal body weight. So you need to look at them and go, how much should this person weigh? And then you have to do that in kilograms. If you don't know how to convert kilograms to pounds, use your calculator, divide how many pounds you think they should weigh by 2.2, and that will give you their kilograms. So we're going to take our packaging and we're going to put some lube in the top part of it here. Now we're going to take our i-gel and we're going to lubricate the back of it and the sides of it and then the tip of it. Do not lubricate this part here. This is what goes to the back of the throat, or to around the glottic opening, sorry. And we want this to remain a little bit sticky. So as the body heat warms this up, it will actually conform itself around the glottic opening, forming a really good seal so no air can escape out of it. Also, make sure that we don't touch anything in the bottom part here that's going to be in their mouth. That's how we introduce diseases into our patient. And the last thing we want to do is introduce diseases that can directly go to their lungs, causing problems. So I've got my i-gel all lubricated. The other thing I need to grab is my tube tie so that we can secure it in place once it's in. So I'm going to go over to my patient here. So as we can see, he already has an OPA in place. My partner would be ventilating him. I don't have a partner, so he's imaginary right now. My partner who's ventilating, I would have them step off to the side of the patient. That way I can be directly at my patient's head. I'm also going to grab a stethoscope and then a colorimetric capnometer. So this is a colorimetric capnometer here. See how it's purple right now? Purple means that it doesn't sense any carbon dioxide. There's not much carbon dioxide in our air around us, but there is a lot of carbon dioxide in air that people exhale. So we're going to use this to make sure that we're actually getting good gas exchange, that this is in the correct spot. So I would coordinate with my partner who's ventilating. I would go, all right, I'm almost ready, so please make sure you keep ventilating the patient. I'm going to place my tube tie in the correct spot. If you look, see that nose? We want to situate it so that when we tie this in place, the nose is by their nose. So I'm going to put that behind my patient's head. And then I would tell my partner, all right, after the next breath, we're going to put in the i-gel. So 3, 2, 1, breath. Take out our OPA. And then take our eye gel. I'm going to put the head into a sniffing position. So just like you're kind of got your head back a little bit, like you smelled your mom's making spaghetti or cookies. So head back just a little bit. Once again, we're going to open that mouth up just like we did for our OPA. And we're going to insert this into the mouth here. And just like the OPA, we're going to follow that hard palate. My mannequin needs a little bit of lube so it passes better. Follow that hard palate until the eye gel doesn't move anymore. Once it is not moving anymore, we can assume it's at the back of the throat and in its proper position. So without letting go, we will put our colorimetric capnometer on the top and our BVM. This is where having a partner comes in handy because they could be placing those on there while I'm getting this finished in place. So then we would start ventilating our patient. We would look at our colorimetric capnometer, and it should hopefully change from the purple that it starts as into this nice golden color. Gold is good. Gold means that we're getting CO2, so we're getting air out of the lungs. We're going to look for chest rise and fall with every breath, making sure that we can see that. And then while my partner ventilates, I'm going to take my stethoscope and I'm going to listen each time they bag. Good, I can hear breath. I can hear that breath. Make sure that we're ventilating both sides of the lungs appropriately. Once I'm sure that we are in the proper spot, we're ventilating appropriately, I'm going to secure this in place. So I'm going to take my tube tie, nose towards the nose, and I'm going to fit the eye gel in place. If you can see this part right here, that actually goes between their teeth so that if they bite down, they can't bite into my tube. Then I'm just going to spin the yellow part till it's nice and tight. Take my free end, pass it through here. Now my tube is secure. We can continue ventilating. Now if we move the patient around a little bit, my tube shouldn't be able to move. So when we go to move the patient to the stretcher, to the hospital bed, our tube shouldn't move at all. Every couple minutes, we should once again check pulse, check lung sounds, make sure we're still getting that good chest rise and fall, make sure that our tube hasn't moved at all. Especially every time we move our patient to a different surface, we need to reassess lung sounds, chest rise and fall, make sure that our tube hasn't moved, which it shouldn't, but sometimes they do. I'll get a little bit closer here so you guys can get a good look at how this looks.